Well, it's 10 o'clock. Good morning, everyone. My name is Arya Shander. I'm the Emeritus Chief of Anesthesiology, Critical Care, Hyperbaric, and Pain Medicine at Englewood Hospital Medical Center. It is certainly my privilege this morning to introduce to you the most accomplished of individuals, Honorio Benzon, who again is a professor of anesthesiology at Northwestern University Feinberg School of Medicine. For those of you who don't know, that's in Illinois. He was chief of pain medicine from 1990 to 2010, and then the director of the Fellowship of Pain Medicine from 1994 to 2006. To say that this gentleman is accomplished is clearly an understatement. He graduated from Far Eastern University in Manila, Philippines, and took a residency in anesthesiology at the University of Cincinnati Medical Center and Northwestern University Feinberg School of Medicine. He has had research training at in the area of neurophysiology at the Brigham and Women's Hospital, and in addition to, again, achieving all these accolades, he's written 95 articles, 110 book chapters, presented over 100 abstracts, all in the field of pain medicine and regional anesthesia. He is the chief editor of the book Essentials in Pain Medicine and the Practical Management of Pain, and is also the co-editor of a book of spinal injection and challenging cases and complication management in pain medicine. Again, to complete his bio, which is, again, is replete with achievements, I think that we'd say here the 45 minutes, which I'd like to reserve for his topic. I think that one of the things that one should know that, again, he is a executive section editor on chronic pain medicine of ANA. He was the board director of the American Society of Regional Anesthesia from 2010 to 2015, and is the chair of the U.S. section on World Institute of Pain since 2015. He is selected as a member of the Alpha Omega Alpha at Northwestern University Feinberg School of Medicine. This was in 2014. So again, I can go on and on as I mentioned, but I think you'd rather hear Professor Benzon describe the ASRA regional and pain anticoagulation guidelines. I think it's sort of misleading. These are not anticoagulation guidelines, but these are guidelines on how to manage patients on anticoagulants. Professor Benzon, thank you.
Thank you. All right. I'm a little embarrassed when so many things are mentioned about me. So I'll go ahead. My disclosure is I'm an advisory board of Sandoz International. They make generic medications, so it's nothing to do with anticoagulants. So what I'm going to do is discuss the changes in the most recent ASRA regional and pain guidelines, the differences between the two, the similarities between the two, and then I'm going to summarize them at the end. I'll talk about the new reversal drugs for the NOACs, and I'm going to add a new topic, the charge scoring system, which I think we should start to incorporate them in our clinical practice. I'm not going to be discussing about the GP2B3 inhibitors because usually these patients are placed on P2Y12 inhibitors, so it basically becomes a P2Y12 inhibitor, clopidogrel, prasugrel problem by the time you see these patients. The hot topic right now in pain medicine is that maybe we shouldn't stop the anticoagulants when we do transparaminal, epidural steroids. We researched the literature, and there have been reports of spinal hematoma, epidural hematoma, foraminal hematoma, and nerve growth hematoma when these procedures are done. So we still strongly feel that these anticoagulants should be stopped before doing a transparaminal. So basically, if you look at this, so I've been part of the regional guidelines since 1998. It's been a long time ago. And I became the senior anchor author in the recent guidelines. And I'm a co-primary author of the pain guidelines. So with the recent guidelines, what I tried to do was to decrease the differences between the two guidelines as much as possible. But in some cases, we couldn't do it, so we have to explain it. So why do we have a separate pain guidelines? Here is a list of 9 patients that developed spinal hematoma during cervical epidural, lumbar epidural, spinal cord stim. All these patients had normal coagulation time studies, and all followed the ASRA regional guidelines. These patients are elderly patients. They have spinal stenosis. It's actually a surgical procedure, spinal cord stim, intrathecal pump. So the board of ASRA decided to create a separate anticoagulation guidelines. So what we did in the pain guidelines was to stratify the risk. You can basically state that the regional procedures are in the low risk, and the intermediate procedures for the regional blocks are the celiac plexus blocks, the deep plexus blocks, the rumbal plexus, and the psoas blocks. So let's talk about antiplatelets. Aspirin says 60% platelet inhibition. What we don't realize is that 10 to 15% of the circulating platelets are formed every day by the megakaryocytes. So by the 4th or 5th day, we already have 50 to 60% of the circulating platelet pool unaffected by the aspirin. That's probably enough to form a clot. It's a little bit fragile, but close to being stable. So for the regional guidelines, we say continue. For the low-risk pain guidelines, we say continue. The problem is in the medium and the high-risk procedures. If your patient had a heart attack, then 4 days you should stop it. If your patient is taking it because they're old like me, then they can stop it for 6, 7 days. They don't really need it. So for the phosphodiesterase inhibitors, we're actually lucky that the half-life of the cilostazol and dipyridamole are the same. They're 10 to 11 hours. So 5 half-lives is 50 hours or 2 days. So we recommend you stop them for 2 days. For regional, you can continue. So why did we decide on 5? I'm going to explain this a little bit more. But if you look at the classic paper by David Greenblatt, I'm sorry. So basically, they're the same. Continue for regional blocks, but stop them between 4 and 6 days for pain procedures. For NSAIDs, we again look at the 5 half-lives, but it's fairly easy. You're talking about 1 to 2 days, except in naproxen, wherein you will require for pain 4 days. So for regional guidelines, continue. 1 to 2 days usually adequate for most of the NSAIDs in the market today. So why did we select 5 half-lives? If you look at the classic paper by David Greenblatt, at 5 half-lives, only 3% of the drug remains in the plasma. There's no reason to go to 6 half-lives because it's still 1%, and then you will have a hard time re-establishing or initiating the anticoagulation. So we felt that the 5 half-life is the reasonable time. So your members of your P&T committee, if you have a new anticoagulant, just look at the half-life, and then multiply it by 5, you already have the 5 half-lives. So let's look at the P2Y12 inhibitors. You can see that, I didn't realize I can use this, that the prodrugs, clopidogrel and prasugrel, they actually undergo 2-step metabolism before they form their active metabolite and then affect the P2Y12 receptor. The direct-acting drug, ticagrelor or Brilinta, is a direct-acting P2Y12 inhibitor. So basically, the regional and pain guidelines are now the same. The clopidogrel costs 60 to 70%. The new drugs cost 80 to 90% inhibition. Very powerful drug, antiplatelet drug. So both guidelines recommend 5 to 7 days stoppage for clopidogrel, 7 to 10 days for prasugrel, 5 days for Brilinta or ticagrelor, and 3 hours for the new drug, cangrelor. It's an IV drug. The resumption is 12 to 24 hours. The reason there's a 12 to 24 hours is that if your patient, if they're going to start the 75 milligram usual dose, it takes several days for it to reach peak effect. Then you can start within 12 hours. If they are, however, started on the loading dose of 300 milligram, that drug is going to take effect within 3 hours, so you better wait 24 hours before you resume it. The problem in the pain guidelines, I don't know how many of you are doing pain, but if we do a spinal cord simulator and do 1 to 3 day trial, then you're talking about 7 days plus 3, that's equal to 10 days, that you can actually do them at 5 days, but do a test of platelet function at 5 days. Either do the Verify Now P2Y12 assay, which most of the cardiology papers use, or the platelet mapping portion of the PEG, which the cardiac surgeon use. I try to correlate the P2Y12 assay and the platelet mapping portion, but have a hard time because it's harder. There are fewer studies on the platelet mapping portion of the TEG. So what we did was we looked at the P2Y12 assay, the residual antiplatelet activity of the clopidogrel, baseline, 3 days, 5 days, and 7 days after the stop. And then if you can see here, at 5 days and 7 days, they're basically the same. It's less than 10% inhibition. 10% or less inhibition is no inhibition. If you are interested in the PRU, platelet reaction units, anything above 260 PRU is basically normal platelet activity. If you look at 5 days and 7 days, there are over 300 PRUs. So if you have the luxury of doing a P2Y12 assay, a Verify Now P2Y12 assay, you can actually do them earlier. I'd like to tell you, though, that there have been case reports of myocardial infarction 5 to 6 days after the clopidogrel was stopped. So, you know, to compromise, you can actually do a test at 5, 6, 7 days. Your hospital is capable of doing it. We're ahead, so we can take our time. With regards to warfarin or Coumadin, there are actually 2 scenarios. The guidelines, both guidelines are different in patients who are not on Coumadin and patients who are on Coumadin. Okay. For patients who have not taken Coumadin, then both the ASRA guidelines, Scandinavian guidelines, German guidelines, ESA, European guidelines said 1.4 or less is adequate, 1.2 is normal. When I was assigned warfarin initially, and we look at all these studies and the clotting factors at several IARS, and at an INR of 1.4 in a patient who have not taken warfarin, they're all above 60%. 60 to 150% is the range of normal activity. They don't call it milligrams or micrograms, I call it percent activity. So if a patient has not taken warfarin, a mild prolongation of the INR is acceptable. The problem, though, if they have taken Coumadin, when you stop them, you stop the Coumadin after 5 days, the ESA European guidelines say 1.4 is okay, slight prolongation. The ASRA guidelines still said we require or we recommend that the NR become normal. Why? We just published a paper in November. We don't have enough patients with a 2.5 to 3 year study. when we look at the concentrations of the clotting factors 7, 9, 10, and 2, at that time, and in the patients with INR of 1.2 or normal, all of the clotting factors were above 40%, 60% or more. Okay, so there were normal activities. In the 2 patients with an INR of 1.3, 1.4, the clotting factors, those with long half-lives, clotting factor 10 and clotting factor 2, had activities of 36, 20, and 37%. So any clotting factor below 40% is a high risk for bleeding. So we recommend that it would be preferable to have the INR 1.2 or less. And if you have the luxury of waiting, if you really want to insist, I would think that for a peripheral nerve block, you can go ahead and do it. But if you're talking an intermediate risk or high-risk pain procedure, if you're doing a lumbar plexus block, a deep plexus block, or a celiac plexus block, then I recommend that you better wait it to normalize. So what about IV heparin? The regional and pain guidelines are not the same. Pain guidelines used to be longer, 6 hours, 4 to 6 hours. The thing you've got to realize, though, is that even Terry Harlacher had a little bit when we were coordinating this. The normal dose of our patients is 5,000, 6,000, 7,000 units per day. If you're talking about the half-life of 1 hour, 5 half-life is 5 hours. That's why we came up with the 4 to 6 hours. Well, the problem, though, is patients who undergo cardiac anesthesia and given 400 units per kilo, 28,000 units, then you're talking about 12-hour, 5 half-lives. So for all intents and purposes, I would think that 4 to 6 hours is okay for 90% of your patients. The only time you would worry is if they put an intrathecal catheter in a cardiac patient, then ask you to take it out and they completely heparinize them, then you have to wait 12 to 24 hours to be safe. So when do you resume the heparin after spinal epidural? We recommend 1 to 2 hours. If you look at the reference there, a classic paper by Rapp and Doherty, over 100 patients, they did diagnostic dural puncture. In all the patients that the IV heparin was restarted 2 hours or later, none developed spinal hematoma. In the patients who developed spinal hematoma were the patients whose IV heparin was started within 1 to 2 hours, mostly within 1 hour. That's why we recommend you wait at least 1 hour, preferably 2 hours before you restart the heparin. So, subcu-heparin, you're talking about BID, TID. The regional guidelines, it's a little bit complicated, the new recent guideline. Again, proceed 4 to 6 hours. You know, you proceed, but preferably you should wait 4 to 6 hours. If they're between 10 and 20,000 units per day, then we recommend you wait 12 hours because of all the prolongation of the half-life, as I told you, with increasing dose. And if they're over 20,000 units per day, then we recommend 24 hours. Then restart 1 hour, 2 hours. Pain guidelines, you know, pain physicians, we're like surgeons, we don't really think about that. So we say, okay, 6 hours for low risk, 24 hours for high risk. And then resume 2 hours and 24 hours. It's easier rather than go through all this pharmacokinetics and trying to explain to them. I'd like to point out that in all the surgical literature, they all recommend that any anticoagulant ought to be restarted at least 24 hours after the surgery. That's what you see in all the succeeding slides, to be 24 hours for pain procedure, resumption of the anticoagulants. Is this good? Okay. Well, just it keep on going. Okay. The TID heparin. This is a new development. The previous regional guideline and the pain guideline said, we have no recommendation, you should not be doing it until we do it, don't do it. But there have been 2 studies now that show the safety of doing spinal epidural in patients on sub-Q TID heparin. I'm going to show you in the next slide. So the regional guidelines say proceed, but you wait 4 to 6 hours from the time the heparin was given. The usual thing, restart 1 hour later. And pain guidelines, again, as I said, 6-hour interval and 24 hours for high risk for surgery like spinal cord stimulation, permanent placement, intrathecal pump, and then restart 2 hours to 6 hours. So this is one of the studies that showed that it's safe to do epidural spinal in patients on TID heparin. 3,500 epidurals, they look at the incidence of PTT greater than 35 seconds. There's no difference between the patients who are on TID heparin and BID heparin. None of the 3,500 patients develop spinal hematoma. So there's another paper, almost exactly the same number of patients, that showed the safety of spinal epidural. That's why both guidelines now recommend you can go ahead and do it on TID heparin. I'd like to point out also that having talked to our surgeons, they're not going to go back to BID heparin. I don't know if in your hospital they're still doing BID heparin, but they found it to be ineffective. So most of them, if not all of them, are now using TID heparin. Low molecular weight heparin, we all know these things, 12 hours for stoppage for prophylactic enoxaparin, 24 hours for therapeutic enoxaparin, 24 hours for dalteparin. I haven't seen any case wherein we stop it for 12 hours. The problem is that the patients we see now are quite obese, that they're now 1 milligram per kilo. They're now on the high dose, so we basically wait 24 hours. So the 12 hours is basically gone. Resumption, we recommended 6 hours, but the FDA came out with a directive that you can resume it after 4 hours. So who are we to question the FDA? Said, okay, 4 hours, 4 hours. Fondaparinux or ASRA, it's got a long half-life. The expert study by Joe Singelin, they were very, very careful in their protocol. It has to be 1 attempt, spinal epidural. The placement has to be automatic. The epidural catheter has to be removed 2 hours before the study was placed, before the patient was placed in the study. So our regional anticoagulation committee said, well, you cannot replicate that in clinical setting, so we have no recommendation. Pain guidelines, we just said, we decided 5 half-lives, 4 days. Okay. This is a very new and very important development. The old guidelines, we had no recommendation for both guidelines for fibrinolytic agents. If you look at the half-life, though, it's only a few hours, 3-4 hours. However, there have been some studies that showed that the inhibition of plasminogen and fibrinogen may last 72 hours, 3 days. The thing, though, is that the Scandinavian guidelines for the last 10 years have been saying 24 hours should be adequate. The half-life is a few hours, 5 half-lives, 6 half-lives, 2 days should be adequate. So after discussion, we decided that, okay, you can stop for 48 hours. I think we should avoid this scenario if we can. It's a big leap of faith. I honestly think 72 hours may be a better way, but I'll give you other reasons why 72 hours is better. But now the ASRA is now saying 2 to 3 days is okay. So if you look at the novel oral anticoagulants, I mean, there's really nothing novel about these things. Warfarin has been blocking both the extrinsic pathway and intrinsic pathway. So But all the drugs that are coming out now and all the drug manufacturers now are directing their drug against the factor 10. Factor 10 is at the junction of the extrinsic and the intrinsic pathway, so they're going to go after factor 10 or the end product, thrombin. That's why all the drugs that will be coming out are either factor 10A inhibitors or thrombin inhibitors. So when BJA, I'm sorry. When BJA asked us to write a review article on the NOACs, we then figured that we have to think about when do we recommend that you stop it and when is it resumed. David Green is a well-known hematologist, and Dr. Bono is the chief of cardiology and the editor-in-chief of JAMA Cardiology. So all the old anticoagulants, stopping the drug before spinal epidural, resuming the drug, are based on studies. I provided you all the studies. At that time, and still that time, there are no studies on NOACs, and when do you stop it, and then you do the spinal epidural. So everything now is based on pharmacokinetics. Are we going to take 2 half-lives versus 5 half-lives? And then the resumption is we're going to take the time for a clot to be stable minus the time to peak effect of the drug, and that's when you're going to restart the drug. So let's go back to David Greenblatt. So with 2 half-lives, 25% still remains. That's why the old European guidelines are 2 half-lives, because they feel that it's already safe to do it at 25% of the drug is still in the plasma, and it will be easier to reinitiate anticoagulation. We felt that 5 half-lives, and this is what ASRA adopted, is better because only 3% remains. It's really safe to do spinal epidural. So the 2 or 3 half-lives is acceptable in patients at high risk, HLP, MI, but the safety of spinal epidural is not assured. So the 5 half-lives we feel is so much better. So the regional and pain ASRA guidelines are the same now for NOACs. 2 to 5 half-lives, 2 half-lives for the simple blocks, 5 half-lives for the spinal epidurals, 2 half-lives for low-risk pain procedure, 5 half-lives for the intermediate and the high-risk procedure. So when do we resume the drug? Nadia Rosencher, a hematologist and physiologist from Paris, recommended 8 hours. So I look at the literature, and there have been several MRI studies that look at the blood several hours afterwards, and by whatever criteria the radiologist had, they felt that the clot matured or stabilized at 7 hours. If you look at the several studies, the NIH-funded studies and the efficacy of fibrinolytics in lysing a cerebral embolism, they were mostly effective within 3 hours. They were rarely effective after 6 hours. So what they're telling us is that after 6 hours, even a fibrinolytic agent will have a hard time lysing that clot. So all the guidelines now are saying, if you assume that 8 hours is adequate for a blood to be stable, a clot, then 8 hours minus 2 hours, all the NOACs, time to peak effect are within 1 to 2 hours. So 8 minus 2 is 6. So all the regional guidelines say 6 hours, you can assume it. The pain guidelines, though, is 6 hours for low risk and 24 hours for high risk, simply because all the surgical literature said don't resume any anticoagulants until 24 hours after the surgery. So they're basically the same. The regional and the pain guidelines you can see for rivaroxaban, apixaban, edoxaban. The only problem, though, is the bigatran. The bigatran is so highly dependent on renal elimination. So what Terry Harlacher recommended was for someone with a normal creatinine clearance, 3 days, mild decrease in mild renal insufficiency, 4 days, 5 days for severe renal insufficiency, and we just talk the median, say 4 days and 6 days for renal. So basically, the regional and pain guidelines are the same for NOACs. There is a new drug, Betrixaban, that we don't, we had the same problem when Apixaban first came because it has a very long half-life, and we didn't know if we should take the tail end or the middle end. But the half-life is 19 to 27 hours for Betrixaban or Bebixa. So 3 to 5 days, 3 days, 5 days for high-risk procedures, deep plexus plaques. So again, you can look at it that they're basically the same, the regional and the pain guidelines. How do we monitor them? The heparin clotting time is the most sensitive for the Vigatran. Most hospitals do not have heparin clotting time. The PTT is the one that people use, but it's the relationship between the result of the PTT and the drug activity is not linear. It's curvilinear. It's good at high dose and good. All it tells you is that there's a drug effect. They cannot tell, they cannot quantify that effect. For the factor 10A inhibitor, then you have to do a factor 10A assay. Easier said than done. Because every laboratory has to be a specific reagent. You have to have a specific reagent for the rivaroxaban for factor 10A rivaroxaban assay, and you have to have a specific reagent for apixaban and edoxaban, respectively. So it's easier at Northwestern, we have one for rivaroxaban. We don't have one for apixaban yet. So when people tell you do factor 10A assay, it's actually easier said than being followed. The nice thing, though, is now we have reversal agents. Either rosizumab or Praxbin, it binds the Vigatran. It's approved by the FDA. There's a nice cohort study that either rosizumab normalized the elevated heparin clotting time in 88 to 98% of patients, and its effect is seen within minutes. So we don't worry now about not being able to reverse the Vigatran. What about the factor 10A inhibitors? We now have andexanet alpha or andexa that was just approved last year. And two nice studies showed the efficacy of andexanet alpha in reversing the anti-factor 10A activity in apixaban patients, 94% versus 21% for placebo and rivaroxaban treated patients. So we now have effective reversal agents for both the Vigatran and the factor 10A inhibitors. I'm just going to go through them quickly. You're not going to see much of them. The regional guidelines for herbal medications say you can continue. There was a case report, however, of an elderly man who was taking 2,000 milligrams of garlic per day. I mean, he liked his garlic. Developed spinal hematoma. When he stopped his garlic, the hematoma resolved. He recovered. So pain guidelines, I think you can go ahead. The chance of anything going wrong is for peripheral blocks is very small. For pain guidelines, you can continue for low risk. For medium risk or high risk, then we want you to stop for 7 days. Ginkgo biloba, you have to take, check the platelets because they have an anti-platelet effect. Dongquai potentiates warfarin, and Danshan prolongs the elimination of warfarin. So we recommend you check the INR if they're on high dose for if you're doing a pain procedure. The antidepressants is something we didn't realize until there were several cases of bleeding, mostly in the oral surgery literature. But when I look at all the laboratory studies, the antiplatelet effect of the antidepressants are basically equivalent to ibuprofen. Now, the antidepressants only involve the SSRIs. It doesn't involve the other antidepressants. So regional guidelines say you can continue the antidepressants rather than doing a black on a depressed patient. The pain guidelines is 1 to 2 week stoppage except for fluoxetine, which it's a complicated story because of the metabolite or fixetine is also prolonged. So, but 1 to 2 weeks is usually adequate. Since we have enough time, I'd like to take more time for the charge scoring, and I start to recommend to my pain colleagues that we should probably automatically think about charge scoring. The charge scoring basically look at the risk of a patient developing MI, stroke, venous thromboembolism. As we know, there's 1 point for congestive heart failure, age over 70, hypertension, and 2 points for someone with previous stroke or TIs. It's a fairly easy scoring. There are several studies, but I only cited one, that the CHA2 score of 2 increased the stroke rate by a factor of 4, and a CHA2 score of 3 increased the stroke rate by a factor of 6. So I think when you have a patient with a CHA2 score of 3, all you need to do is 1, 1, 1, 3, then you have to talk to them about the risk of stopping anticoagulant. You need to do the black, you need to do the pain procedure. But more important, you really have to consider putting them on the low molecular weight heparin bridge therapy and stopping the enoxaparin or dalteparin 24 hours before. In that scenario, you're covered. You don't worry about the patient having stroke or MI, and you can go ahead and do your procedure. So I'm going to go through them quickly. For the antiplatelets, they're basically the same, except for aspirin and NSAIDs. The regional said continue. The pain said 4 to 6 days, based on whether you have a heart attack or not. And NSAID is 5 half-lives, 1 to 2 days. They're all anticoagulants. You can basically say that they're the same. Warfarin, enoxaparin, dalteparin, fibrinolytic agents, they're the same. The Subcut Heparin is a little different, but it's still 4 to 6 hours. The only time you've got to realize if there are 10 to 20,000 units or over 20,000 units, then you may have to wait 12 to 24 hours. But for pain, it's 6 to 24 hours. So for all intents and purposes, the regional and pain guidelines are the same. Resuming the old anticoagulants, again, they're all the same, except the 24-hour requirement for high-risk procedures. Spinal cord stim, intrathecal pumps, these are major surgeries that we recommend 24 hours. For the NOACs, they're all the same, again, except for the Bigatran. The regional pain guidelines are the same, 3 days, 3 days, 3 days. The Bigatran is based 3 days for patient with normal renal function, and 4 to 5 days in someone with renal insufficiency. And resumption is 6 hours for regional and 24 hours for pain. So we're done. I talk about changes in the most recent ASRA regional and pain guidelines. I try to explain why we have to have a separate guideline for pain. You're dealing with elderly patients, patients with spinal stenosis, patients with scarring post-laminectomy. It's less forgiving. Talk about reversal of NOACs. And I also talk about the charge scoring system. Thank you very much.
Thank you. We'll open with time for questions. Thank you, by the way, for finishing before the allotted time. Maybe I'll kick off with a question where I think there's a little bit of discrepancy. When you look at the hematological literature, the general population has 70% of people have an INR greater than 1.0. So already we're starting off with an increased INR in the general population, and they're not on warfarin. But according to the other hematological and coagulation data, you need about 25 to 30% of a clotting factor to create a clot, which is about an INR of anywhere from 1.4 to as high as 1.7. But in the guidelines that you have versus the Europeans go to 1.4, and you've gone to 1.2, which, again, we're talking numbers, of course, but that was based on only 2 patients.
Yes.
And I could say the same thing then for the half-life, because phenotypes may have clearly elongated half-lives. That was not tested. So if you don't mind just seeing how we can clear that. I love 1.3, by the way, but I'll take 1.7 depending on the situation.
So again, there are 2 scenarios here in patients who have not taken warfarin. 1.4 or less, slight prolongation is acceptable. I'd like to make that clear. The problem occurs when patient had been on warfarin and you stop them. And if you look at the data, actually, in a normal ASA physical status 1 patients, 3 days stoppage is enough. However, most patients with minor comorbidities will require 5 days for everything to normalize. So we were caught between 1.4 and 1.2, so it's so close to each other. We're still gathering data because it's so hard to find patients with 1.3 to 1.4. What I presented to you is a 3-year study. These studies are very expensive, by the way. I mean, those are $50 something per clotting factor. But we couldn't identify them. I think that you really had to make your own clinical decision. If you're talking about compressible blocks, peripheral nerve blocks, I see no reason, even 1.6, I'd go ahead. Trigger point injections, all the low-risk procedures, I see no problem. However, if you're dealing with psoas deep plexus blocks, when there have been reported cases of pericapsular hematoma, perirenal hematoma, lumbar psoas muscle hematoma in patients not on anticoagulants. Now, I realize there are a lot of other factors coming into play. I would try to hold up on the 1.3, 1.4, and if you're really interested, I'd say 1.4, I followed the ISA guidelines. We don't have enough patients to really, that's why it wasn't a brief report, because the problems were having so many surgeons telling us, okay, so axillary block, interscalene block, peripheral nerve blocks, I have no problem doing 1.6. But when they start asking me to do it in paravertebral blocks, lumbar plexus block, deep plexus block, celiac plexus block, before they send their patient home, then there's a difference there. And that's what I'm trying to say. You have to know these guidelines, but then you have to document that you did this thing. There's a lot of factors other than numbers in what decides what results in a hematoma.
I think that makes sense. And the other issue, which is not addressed by the guidelines, is the possibility of looking at 2 half-lives versus 5 half-lives. If you're in the middle, would you recommend then doing an activity test to see if there is, where the activity is for that particular patient in terms of reduction down to 20% of activity, of either inhibition or of anticoagulation?
Now, I think we again go into the stratification of risk. I think 2 half-lives is adequate for peripheral nerve blocks, low risk. But when you're dealing with spinal epidural in an elderly patient with spinal stenosis, it's kind of hard to justify. Yes, if you have the luxury of doing those things, but then it's hard to get how are you going to get unless you do a point of care assay, then you can do it. But a lot of times it's very, very hard to get these things done. If it's an emergency, then it becomes a clinical decision. Then just go ahead, think what you think is best for the patient. And talk to the patient, talk to the surgeon, document, and then go from there.
Thank you. Yes.
Yeah, Barb.
Would these recommendations be the same or differ in the obstetric patient population?
That's why I don't deal with obstetrics, because I think it's basically the same. Now, first of all, I'd like to tell you that the incidence of spinal hematoma in the obstetric patient, peripartum hematoma, is very, very small, because there is a, they tend to clot better. Interestingly, what's against it, though, is they tend to be more vascular in epidural space. In fact, if you look at the papers by Jill Meyer and Brian Bateman, and when they look at the case reports in the OB population, they were not able to find one, I believe. We were able to find some, because what we're doing now is looking at all the case reports of spinal hematoma from the beginning on. We have 600, I think now it's the biggest one. We hope to be done this year. But so if you look at the SOAP consortium from Michigan, Brian Bateman, the whole thing, they made the comment that they really did not see any cause and effect, or the prospective study done, there was no spinal hematoma in an OB patient. Yeah.
If I may add to that, and I agree, I think, first of all, the risk in terms of what we have in terms of frequency of bleeding from neuraxial blockade is very, very low. So you're going to need probably hundreds of thousands of patients to actually make a determination. But keep in mind, this population to start with is hypercoagulable, A. B, most of these patients, or if I could say almost close to none of these patients, are on these medications that you described, because there's really no need unless they have some other issues such as a factor V Leiden or other abnormality which puts them at risk. We now know, and there was a review, by the way, in ANA last year, we now know about the fact that we're picking up on, when we're doing genetic testing, on factor 11 deficiency, which is a real issue, because in the past these patients were silent and we still do an epidural and bleeding was still very rare. But now if you see that their factor 11 is low on these tests, the hematologists are now recommending intervention, which is probably higher risk for the patient than the actual doing the epidural. But our main concern this morning is really looking at the anticoagulation in patients who are having pain procedures. Clearly, neuraxial pain relief for the parturient is an issue, but they're a completely different population, I think.
Yeah, in this study is talking about, in that consortium of SOAP consortium, anticoagulation, several thousands of patients. There was not a single case of spinal hematoma. Yes, sir.
What do you think about option to use thromboelastogram for borderline on clear situation as an additional method or made decision?
Yeah, I have done studies on TEG. It's harder. I realize it's the trend now, but it's harder for me to. When you look at the result of a laboratory assay, then you look at the publications that would say, okay, at this thing, at this number, it's equivalent to, is it safe to do it? And there really has been no good studies that correlated the numbers in the TEG to safety in spinal epidural. There have been numbers now in the P2Y12 assay and a few numbers in the platelet mapping version, maybe 2 papers in the BJA, but there's not a whole lot on TEG, so I really cannot comment. I'm sorry.
But I think we have to be careful today. I think that we're talking about viscoelastic testing. There's more than thromboelastography out there to start with. And again, there was just a publication in the International Journal of Obstetrics and Gynecology looking at the blind spots of viscoelastic testing. And one of the blind spots that we have is it's better than platelet platelet number. We can get some activity, but it's not direct. It's a surrogate marker of platelet activity. And the other, of course, is the fibrinolytic activity is another area which is somewhat obscured for us. So I think we need more data. However, if you get a completely normal viscoelastic testing, and you want to move on, and your say your half-life is in the range as you described, I think that that's probably an added, maybe added confidence in terms of the patient ability to clot. But it's not really good for looking at the details of platelet function or the fibrolytic activity. Yes?
Yes, sir.
You mentioned that you would perform a peripheral nerve block in a patient with an INR of 1.6, but would you perform a Neuraxial block, especially an epidural, in a patient with the same level?
Peripheral nerve block, I would. Neuraxial block, I wouldn't.
What's your number for your Neuraxial blocks?
If the patient was not on Warfarin, 1.4 or less. If a patient was on Warfarin, 1.2 or normal, it has to be normal.
So
You also have to think about other factors. The patient elderly.
European standards then as opposed to the ASRA standards, if I understand that correctly.
We're trying to do now, if you look at the most recent ASRA guidelines, we now have Eric van der Meulen, who represented ISA, and Wibke Gogarten, who's the lead editor in ISA. So we're slowly trying to merge, but so I think the regional, I think, is more, it's closer now, but the pain is totally separate. There are no pain guidelines from the other continent, other than the US. But we were, I wouldn't say smart, but we were good in it. Our pain guidelines is endorsed by several national, international organizations outside of the US. And we have representatives from Europe, so there's less discussion there. But I see your point, but there's still the controversies now between the ASRA and the ISA guidelines are getting narrower and narrower. And again, as I told you, the two main people who are involved there who've written a lot of papers, Eric van der Meulen from Belgium and Wibke Gogarten from Germany are very much involved in the recent thing. We had a lot of counter discussions, and hopefully we'll arrive at the same thing. Then we won't have to worry.
I think there are two issues which sometimes get lost. One of them is the ability of a patient to actually create a clot at different levels of INR. And the other, which I think you described, is what is the risk of bleeding for a patient?
Yeah.
And I think that the guidelines clearly are again, relying on the risk of the bleeding, whereas we know that we can argue the INR here for the whole 2 days that we're going to be here, but I could tell you, you certainly can create a strong clot and the patient has an INR 1.7. So again, a lot of people would nod their head. Would you do an invasive procedure under those circumstances? And the answer is, it depends clinically if the patient needs an emergency versus what you can wait and address it. The elevated INR, though, sometimes actually can occur with patients who have inhibitors, which means that they're actually procoagulant, they're hypercoagulant. And under those circumstances, again, you have to do other testing, but the INR is not finite. I think that the nice thing about the guidelines, they really emerge of assessing the risk of the patient.
The other thing is these are guidelines. They're not mandatory. And by nature, and I have represented ASRA and ASA in the ACC, AHA anticoagulation guidelines. These guidelines, by nature, are more conservative. Because if we're going to do this thing, people push a little bit more and do something. So their recommendations, they're not mandatory. You say, this is what they do, this is what I think be done. I discuss with the patient, then go ahead, document it.
What's not addressed in the guidelines clearly is that population of patient who has an elevated INR but not on warfarin. What about liver disease?
That's true.
So liver disease, the problem is that when you do an INR in these patients, you're only getting one side of the coagulation profile, which is really the procoagulant. What we need also is again, assays for protein S and protein C. And if there is a ratio that you can create, and if the ratio is balanced, those patients, even though they have an elevated INR, may be considered for a regional block under those circumstances, because all it is that the numbers are different, but their ability to clot remains as the general population. Someone had another, I don't know if you want to comment on that, but yes.
Yes, sir.
My institution, we do a lot of hybrid vascular procedures, so we use a small gauge spinal needle, put a spinal in, and then the radiologist or vascular surgeon asks us to give 10,000 units of IV heparin. What do you think about managing that situation?
So they want you to the spinal epidural, then they give IV heparin, or they want to give IV heparin, then they ask you to do the spinal epidural?
No, we're doing the spinal first. About maybe 45 minutes of radiology time and putting the graft in is when they want us to give the IV heparin.
So you did the spinal. Well, IV heparin is not a fibrinolytic agent, so the chance of anything happening is very small. I don't foresee a problem.
But like my colleagues are mostly worried about hematoma risk. Like you're talking about 25 gauge Whitaker needle for the spinal. You're talking about 4 to 5 hour window. It's often they're asking for the heparin often faster than that. Yeah, quite
Within the first hour after.
Yeah, actually, yeah.
It's hard for me to comment on that one because if there is will it cause more bleeding? I'm not sure. I mean, if you're giving a fibrinolytic agent, then definitely, but you're not giving a fibrinolytic agent. Now, does giving an anticoagulant in someone who's active bleeding bleeds more probably? Does giving an anticoagulant in someone who already has a clot, but a fragile clot? Then those are two scenarios I cannot answer. I'm sorry.
This is mostly elective situation I'm talking about, not emergency.
Yeah, I know.
Well, but if you can extrapolate, if you can, from the guidelines, you had a situation where you're willing to do a neuraxial block under circumstances, but it has to be a single injection, and it has to be atraumatic, which is what so I think you probably cross over in terms of.
Also the RAP endoverty study, in all the patients that the IV heparin was given 1 hour after the dural puncture, none developed spinal hematoma.
Thank you.
So I think that's reasonable. Now, if there was it was a bloody tap, a lot of bleeding, then I would tell them to hold up as much as possible, but it should be no problem.
You could still be anxious, but doesn't sound like it's risky. Any other questions? They've been great. Yes, please.
To your point about the possibility of bridging patients with atrial fibrillation and higher CHAD scores, in my experience, most institutions have really gone away from that practice since the bridge trial.
Yes.
Despite a fair amount of people with doubts about CHADS 5, 6, because there weren't enough of those patients in the study, the risk of bleeding, very procedural bleeding with bridging is much higher, and no difference in stroke or PE.
Yeah, that was a hot topic during the American College of Cardiology ASRA Anticoagulant Symposium 3-4 years ago when I was represented ASRA and ASA. And they made a big deal because the primary author was there, published in New England Journal of Medicine, that low molecular weight heparin bridge therapy does not work. But what are we going to give them or offer them in the meantime? If the CHAD score is high, are you going to stop it for 5-7 days and not give them anything? So what is the option? That's why you need to discuss with the patient and tell them this may work, this may not work. But I'm glad you brought that up. And the editorial that were coming up, and we recommended that one. I know that it doesn't work all the time, but what are we going to recommend in the meantime? Thank you for bringing that up here.
Well, we want to thank you, Professor Benzon, for a wonderful presentation and a great discussion. Please remember